teachers and my colleagues. Today's discussion is on polycystic ovarian syndrome or PCOS. We begin the discussion with two cases of PCOS who had presented to our outpatient department. The first patient, 26-year-old lady, presented to us in January 2010. She had been married for 4 months and she complained of irregular cycles for the last 3 months. On taking a detailed history, she revealed that she was on treatment for the past 6 months for acne and excessive hair growth. While on treatment, she developed delayed cycles for 3 months past. Her menstrual history revealed that she had cycles once every 30 to 40 days. Her past medical and surgical history were not significant. Her family history showed that her mother suffered from diabetes mellitus. On examination, both the general survey and per abdominal examination revealed obesity. She had acne, mild hirsutism, and acanthosis nigricans, as can be seen here. Her per vaginal examination was also within normal limits. Her blood test showed an elevated LH level. The LH-FSH ratio was more than 3. The free testosterone and the dehydroepiandrostenedione sulfate, that is the DHEAS levels, were also increased. The fasting and the postprandial blood sugar levels were increased. However, her thyroid profile and prolactin levels were within normal limits, which ruled out the other differential diagnosis of PCOS, which will be discussed later on. The ultrasonography showed polycystic ovaries. A provisional diagnosis of polycystic ovarian syndrome was made. She was placed on tablet metformin, initially 500 mg once daily and then 500 mg twice daily, and on oral contraceptive pills containing estrogen and cyproterone acetate for 3 cycles to control her acne, hirsutism, and to regularize her cycles. She is still on regular follow-up and is doing quite well. Our second patient presented to us in August 2009. She was 22 years old, married for more than 1 year. She presented with complaints of inability to conceive for the past 1 year. She had no history of any contraception usage and she had received no other treatment. Her menstrual history showed that she had cycles once every 2 to 3 months since her menarche at the age of 13 years. Her past medical, surgical history and family history were not significant. On examination, in contrast to her previous patient, she was lean. She had no signs of acne, hirsutism, or any skin changes. The per abdominal and per vaginal examination were also within normal limits. The blood test showed an elevated LH-FSH ratio of more than 3. But in contrast to our previous patient, again, she had normal levels of free testosterone, DHEAS, and glucose tolerance test. However, her ultrasonography showed bilateral polycystic ovaries. Again, a diagnosis of polycystic ovarian syndrome was made. Since her primary concern was infertility, she was started on ovulation induction drugs, that is clomiphene, and metformin for the initial 6 months. She failed to conceive on this regimen. She was posted on laparoscopic ovarian drilling, following which she was placed again on clomiphene for the first half of the cycle and progesterone in the later half for 3 months. She successfully conceived on this treatment. At present, she is 6 weeks pregnant, regularly attending antenatal clinic of this institution. So to come to a brief discussion on PCOS. Polycystic ovarian syndrome is variously known as the polycystic ovarian disease or the popularly known Steen-Leventhal syndrome, to name a few. The magnitude of the problem. It is one of the most common female endocrine disorders, thought to be one of the leading causes of female anovulatory infertility and hirsutism. Various studies have shown that 5 to 10% women of childbearing age, that is 20 to 40 years, and around 30% of women of all age groups have some or the other symptoms of PCOS. The importance of the problem lies in the fact that women with PCOS have increased risk of infertility, miscarriage, the metabolic syndrome consisting of insulin resistance, dyslipidemia, type 2 diabetes mellitus and cardiovascular disease, and also endometrial cancer and probably breast cancer too. The disease is a complex endocrine disorder primarily affecting women of childbearing age, characterized by increased androgen production and ovulatory dysfunction. The definition widely accepted these days is the Rotterdam criteria of 2003, in which two of the following three criteria must be met in order that a patient be stamped as a case of PCOS. These include oligo and or anovulation, proof of excess androgen activity either clinically or biochemically, polycystic ovaries demonstrated by ultrasonography, which means 12 or more follicles, each 2 to 9 millimeter in diameter, and or an increased ovarian volume of more than 10 cc. The pathogenesis of PCOS is still under study. The initial trigger that offsets the internal milieu is still unknown. Various theories have been propounded. It has been seen that in both lean and obese PCOS women, there is a component of I'm sorry, the pointer is not working. There is a component of insulin resistance. This high insulin levels will stimulate the pituitary to increase the pulsatile frequency of the LH. This increases the ovarian androgen production. Increased insulin levels also stimulates the ovaries directly to produce increased androgens. It stimulates the liver to decrease its secretion of sex hormone binding globulin, thereby again increasing the free testosterone level. This increase in bioavailable androgens leads to increased conversion in the peripheral tissues to estrone, which again stimulates the LH frequency. The obesity adds on to this cycle by increasing the peripheral conversion of androgens to estrogens. The ultimate result is a change in the internal microenvironment of the ovarian follicle from one of an estrogenic component to an androgenic one. This leads to the arrest of the follicles in a particular stage and prevents ovulation. Thereby, a normal ovary is converted to a polycystic one. The diagnosis is clinical and by investigational workup. The presenting complaints may be gynecological or general. Menstrual abnormalities and infertilities constitute the gynecological complaints, while the general ones include hyperandrogenic symptoms, obesity, dermatological afflictions, and behavioral problems. Menstrual abnormalities may be presented as delayed menarche, onset of irregular cycles or breakdown of previously regular ones, oligo or amenorrhea at one end of the spectrum to even polymenorrhea at the other. Patients may also present with infertility. The general features include hyperandrogenic symptoms of hirsutism, that is excessive terminal hair growth in a male pattern, acne, and androgenic alopecia at the other end. Truncal obesity is present in around 60% of women with a BMI of more than 30. Skin changes include acanthosis nigricans, which is a greyish-brown velvety discoloration of the skin seen in the nape of the neck, in the axilla, in the groin, etc. Patients may present with psychological problems of anxiety and depression. The investigative workup includes biochemical tests and radiology. In the biochemical tests, it is found that the free testosterone and the DHEAS levels are increased. The LH levels are increased such that the LH-FSH ratio is increased to more than 3. The fasting and the postprandial blood sugar levels may also be increased, and the fasting insulin levels are also increased. The thyroid profile and the prolactin levels must be done in order to exclude the other disorders. Ultrasonography shows 12 or more cysts or follicles, each 2 to 9 millimeter in diameter, arranged in the periphery of one or both ovaries. There is also an increased ovarian volume of more than 10 cc in majority of patients. Coming to the differential diagnosis, there are a variety of disorders which may present with signs and symptoms of PCOS. thyroid disorders may present with obesity, menstrual irregularities, and inability to conceive. Hyperprolactinemia may similarly present with menstrual irregularities and with infertility. Cushing syndrome shares many of the features of PCOS in that it presents with obesity, skin changes, emotional disturbances, hyperandrogenic symptoms, and infertility. Androgenic tumor and adult onset congenital adrenal hyperplasia may present with acne, hirsutism, androgenic alopecia, menstrual irregularities, and problems in conception. However, diagnosis with the help of biochemical tests and ultrasonography has been made clear-cut by the Rotterdam criteria, and PCOS can be comfortably diagnosed. The management should be tailored to the individual patient's needs. Lifestyle modification remains the prime intervention. The other goals are decreasing insulin levels, restoration of regular menstruation, treatment of acne and hirsutism, and restoration of fertility if the case be. Lifestyle modifications include weight reduction. This is very important because it can ameliorate majority of the symptoms and signs of PCOS. Weight reduction may be brought about by dietary changes, regular exercises, cessation of smoking, stress avoidance, etc. Patients are advised to have small frequent meals throughout the day instead of 3 to 4 large meals. They are encouraged to have foods of lower glycemic index like whole grains or oats. The calorie intake from carbohydrates should be restricted for the non-obese to 50 to 55% and for the obese to 40%. The calorie intake each from proteins and fats should be around 20 to 30%. They are encouraged to have plenty of fresh fruits and vegetables and around 8 to 10 glasses of water per day. Regular exercises in the form of 30 minutes of brisk walk or aerobics every day and yoga or deep breathing exercises are also beneficial. The insulin levels may be decreased by lifestyle changes as already stated earlier. Medication in the form of metformin or pioglitazones help in combating the insulin resistance. Metformin should initially be started at a low dose of 500 mg every day and then gradually increased up to a maximum of 1500 mg per day. Menstruation regularization is easily done with the help of prescribing oral pills. They may contain a combination of estrogen with either progesterone or cyproterone acetate if the patient has hirsutism and acne, or drospirenol if the patient is suffering from premenstrual symptoms. An alternative regimen is prescribing progestrogens in the later half of the cycle. Acne and hirsutism may be cured by prescribing hormonal suspensions of oral contraceptive pills, medroxyprogesterone acetate, the GnRH analogs, and the glucocorticoids. Anti-androgens like cyproterone, spironolactone, and flutamide may also be given. Other drugs include finasteride, metformin, and ketoconazole. Patients refractory to the medical treatment may be offered electrolysis or laser treatment. Fertility can be restored by lifestyle modification alone, which induces ovulation. Ovulation induction drugs like the anti-estrogen clomiphene citrate or letrozole, which is an aromatase inhibitor, may be given. Clomiphene citrate may be given in a dose of 50 mg once daily to thrice daily in the first half of the cycle. Letrozole is prescribed as 2.5 mg once daily from day 2nd to day 5 of the cycle. If patients are resistant to ovulation induction drugs, they are put on parenteral GnRH analogs. An alternative is the laparoscopic ovarian drilling. To touch upon laparoscopic ovarian drilling very briefly, here we see the two ovaries which are cystic. These blue cysts are seen very clearly here. In laparoscopic ovarian drilling, 4 to 10 of such follicles are punctured with electrocautery. This reduces the ovarian volume and induces ovulation. She is one of our patients at present admitted in our ward. She had presented to us in 2009 with chief complaints of infertility. It was diagnosed to be a case of PCOS. She was posted for laparoscopic ovarian drilling. She conceived successfully and she has an EDD on the 6th of August this year. She is awaiting delivery. The treatment results show that only a 5% reduction in weight regularizes menstruation, restores fertility, and cures the hyperandrogenic manifestations of acne and hirsutism. Around 40% patients conceive on treatment and around 60% have regularized cycles. So to summarize, polycystic ovarian syndrome is one of the most common endocrine disorders in women worldwide, potentially having serious long-term sequelae. The varied presentation of PCOS may often delay diagnosis and initialization of therapy. However, individualized management has proved to be effective for most patients, thus giving hope for many around the world. Thank you all for your patient hearing.